All right, if you're a medical trainee, you've probably heard of Mast Cell Activation Syndrome, or MCAS, and let's be honest, it can be a real head-scratcher. The symptoms seem to pop up everywhere, but getting to a clear diagnosis, that is anything but simple. So today, we're going to put the pieces of this puzzle together, step by step.
So let's paint a picture. You've got a patient in front of you. They're telling you about these episodes, flushing, hives, some pretty bad abdominal cramping. Your first thought might be, okay, this is just a straightforward allergy, right? But what if it's something more? What if you're looking at a much more complex underlying mast cell disorder? That's the exact question we're going to get to the bottom of.
So here's our game plan. First, we'll tackle why this is such a clinical puzzle. Then we'll build a really simple framework with the three main types of mast cell disorders. From there, we'll zero in on what MCAS actually is, walk through the three absolute must-have diagnostic criteria, cover the workup, and then we'll wrap up with some really practical clinical pearls and common pitfalls to watch out for.
Okay, let's dive right in. Before we can even talk about the disorders, we have to get to know the main character in this whole story, the mast cell itself.
Think of mast cells as your immune system's frontline soldiers. They're strategically placed in all the tissues that face the outside world. You know, your skin, your gut, your airways. They're the first responders, standing guard and ready to sound the alarm against any foreign invaders.
So when these mast cells get activated, they release this chemical cocktail that causes all the classic symptoms we see here: flushing, itching, hives, even full-blown anaphylaxis. But here's the kicker. These are the exact same symptoms you see in a classic allergic reaction. And that clinical overlap, that's what makes this whole thing so tricky.
So, how do we cut through all that complexity? Well, it's actually incredibly helpful to think about mast cell disorders in three big buckets. This framework is going to be our roadmap for making a diagnosis.
Okay, so the key difference here is the cause. In primary disorders, like systemic mastocytosis, the problem is with the mast cells themselves. They're abnormal and there are too many of them. In secondary disorders, the mast cells are perfectly normal. They're just doing their job and reacting to a clear trigger, like a peanut allergy. And then you have idiopathic disorders, where normal mast cells are firing off, but for the life of us, we can't find a trigger.
And here's something really important to keep in your back pocket. These categories aren't always separate little boxes. You can absolutely have a patient with a mixed picture. For instance, someone could have a primary disorder, like mastocytosis, and also have a totally separate classic food allergy.
Okay, this brings us to a really common point of confusion, especially for trainees. What exactly is mast cell activation syndrome? Is it a diagnosis? Is it a symptom? What's the deal?
This quote just nails it. MCAS isn't one single disease. Think of it as an umbrella term. It's a way to describe a certain clinical picture, a set of symptoms that can be caused by any of those three categories we just talked about: primary, secondary, or idiopathic.
So what does that mean for you in the clinic? It gives you a clear path forward. If you have a patient who looks like they have MCAS, your job is to first play detective. You have to investigate and rule out any underlying primary or secondary causes. Only after you've done that can you land on a diagnosis of idiopathic MCAS.
All right, lean in for this next part, because if you take away only one thing from our time together, this is it. These are the three core criteria you absolutely must have to make the diagnosis.
And I really can't stress this enough. The patient has to meet all three of these criteria. Not one, not two, all three. This is so important because it helps us avoid both overdiagnosing and underdiagnosing this condition, which are both huge problems.
So let's break them down. Number one, the patient has to have those typical episodic symptoms, and they have to involve at least two different organ systems. Number two, you need cold, hard, objective lab evidence that mast cells release their mediators during one of those episodes. And number three, their symptoms have to get better when you treat them with meds that target mast cells, like antihistamines. You need all three pieces of the puzzle. Now, that second criterion, getting the proof of mediator release, that's often where the rubber meets the road. So let's talk about the workup and specifically the most important lab test you're going to order. And that test is for serum tryptase. Tryptase is a protein that's stored inside mast cells. So when we measure it in the blood, it gives us a pretty specific window into what the mast cells are up to. It tells us about both how many there are and whether they've recently been activated.
But here's a super important detail. It's not enough for the tryptase to just be a little high. To meet that second criterion, you have to use this very specific formula. You need to show that the tryptase level drawn during or right after an episode is at least 20% above the patient's baseline value, plus an additional 2. You have to do the math on this one. It's absolutely key.
So what happens if the tryptase testing is, kind of murky or inconclusive? Well, you're not out of options. You've got a plan B. You can look for other evidence by measuring the breakdown products of other mast cell chemicals in the urine, like N-methylhistamine.
Okay, let's bring this all back to the real world, back to the clinic. What are the things that should make your ears perk up and think mast cell disorder? And, just as importantly, what are the common traps to avoid?
You should really have a high suspicion for a primary mast cell disorder if a patient tells you they have really severe anaphylaxis that makes their blood pressure drop, especially from bee stings. Another huge red flag is a baseline tryptase that's always high, say over 20. And of course, if you see those classic skin lesions known as urticaria pigmentosa, you've got to think about it.
Now, on the flip side, there are a few things that are pretty unlikely to be a primary mast cell disorder on their own. This includes things like just fatigue or brain fog without any other systemic symptoms. Same goes for chronic hives all by themselves. These things alone probably don't warrant a full MCAS workup.
So, when do you phone a friend? Well, if you really suspect a primary disorder, especially if you've got that elevated baseline tryptase, or if the case is just really complex and you're not getting clear answers, that's the time to refer to an allergist, immunologist, or a hematologist who specializes in this.
And this really brings us full circle. The whole challenge with MCAS is walking this very fine line. If we overdiagnose it, we can cause a lot of unnecessary anxiety and testing. But if we miss it, we're denying patients a diagnosis and treatment that could really help them. Sticking to those 3 criteria is our best defense against either extreme.
And this leaves us with a pretty fascinating question for the future. Right now, we label a lot of these cases as idiopathic because we can't find a cause. But as we get better at identifying new genetic markers and environmental triggers, how is that going to change things? How many of these idiopathic cases will we be able to reclassify? It's really going to reshape this entire field for the next generation of clinicians.